So, good evening, everybody, and welcome to this ORF OrthoTV postgraduate web class. And it over to Janki for further proceedings. Over to you, Janki.
Okay, welcome everybody. I think today the lecture is going to be on examination of the spine, and we have our spine surgeon, Dr. Gautam Prasad, who's going to be giving this talk. I think spine is a case which is very likely to be there as one of the long cases in the normal course of the DNB exams. I'm not sure how the next few exams are going to be, whether they change to OSCE for most of the clinical examination part or not. However, I think it would still be important to know the basics of clinical examination of the spine, even if it is in the OSCE mode. So over to you, Gautam, to give the talk. Yeah. Gautam?
I'm coming.
Yeah.
Yeah.
Share your
Good
screen.
evening, everyone. Yeah. Am I visible?
Yes,
sir.
Yeah. So we'll be talking about examination
Your
of
screen, you need to share your screen.
Oh.
So have you got the talk open on your laptop?
Yes, sir. Yes, sir. Yes, sir.
In the bottom of the thing, you'll have
Yes,
a
sir. Yes, sir. Yeah.
share screen, do that, and then,
Is it now being shared?
yeah, it's coming.
Yeah.
So now,
Yeah. Yes.
press
Yes.
that,
Yes, sir.
maximize it, it's still on.
Yeah.
Yeah, great.
Yeah. So clinical examination of spine. So the basic thing that that one knows is I see what mind knows. So if your mind doesn't know what is right, what is wrong, probably we won't be able to judge whether we are doing the exact examination which is expected of us or not. So let's first go through the basics, because often we don't we fumble in the basics, and that's where we go wrong. So there are now 33 vertebrae, 31 pairs of nerve roots, 23 discs, and the spinal cords that extends from the foramen magnum to up to the level of L1, L2 disc.
Hello? Yeah.
Below this, there is no cord as such.
Yeah, tell me.
Hello.
Ashok, you need to mute yourself.
So below this level, all the roots which are there, those are actually the quada equina. So the lesion which affects the spinal cord is totally different from what we get when there is a affection of the quada equina. Whenever the spinal cord gets affected, there is a human kind of sign of pictures present, upper motor neuron disease, which will be seen. And whenever there is a compressive element on the lower side, below the L1, L2 disc, there will be local symptoms because of the element type of pictures will be present. So here's the anatomy of the spinal canal. The vertebrae, there is a spinal canal in which the spinal cord is present. So this is the anterior aspect. This is the posterior or the dorsal aspect. So if you look at the spinal cord, like this is as if we are looking at the spinal cord from behind. So this is how the spinal cord is present. And in this, there is something called as dentate ligament. Now, this is something which holds the spinal cord to the dural membrane from within. That's why whenever there is a lesion, even from the front, right in the midline, the motor affection is there. So if we check out the tracts, it's more laterally. The motor part is more laterally and the sensory part is more posteriorly. So many times the examiners, they are actually fond of asking this question as to why, if there is a lesion right in the center anteriorly, many times there is a motor affection, though the motor tracts are more on the anterolateral aspect, not exactly in the anteromedially place. So the point I want to raise here is, whenever there is anterior compression, this dentate ligament, there is a dent there is an attachment to this level. It is anterolaterally attached. So even if there is a compression right in the center, many times the tracts on the sides, they get traction. There is a traction injury, and that's why there is motor involvement earlier seen with any compressile element, even in the midline. We should be well aware of the various plexus, the brachial plexus, as well as the lumbar or the sacral plexus. Every spinal segments that we actually come across, there is the two vertebra in together with the disc in between, they form a spinal segment. So whenever we come across a segment, the particular root which is getting affected, that we should be well aware of. And that is very important, because that's how, when we come to know the which root is affected, accordingly we'll have to judge the level of spinal vertebral lesion. That may not be the same. The reason is because there are 8 spinal nerves, whereas there are only 7 vertebrae. So in cervical spine, the corresponding nerve will exit above the pedicle, whereas in the thoracic and the lumbar spine, the corresponding nerve root will exit under the under the same pedicle. That means if a C5 C6 disc is getting protruded and it's compressing the exiting root, then the C6 root will be getting affected. Whereas in a lumbar spine, if L4 L5 disc is getting protruded and it's compressing the nerve root, it's most likely to affect the lower L5 root. Now we need to know which root is affecting which, is supplying which muscles, and what are the actual sensory dermatome. Grossly, we can just memorize this diagram. The C5 is innervating the deltoid, C5-6 for the biceps, wrist extensors is C6, wrist flexors is 7, the finger extensors is C7, finger flexors is C8, and introsci is T1. If we come to the sensory dermatome in cervical spine, the C2, C3 is more over the occipital area and the angle of jaw, C4 over the supraclavicular area, C5 over the upper arm, C6 comes on the lateral aspect as is being shown here. So C5 here, C6 on the lateral aspect of the forearm, C7 in the middle finger, C8 on the medial aspect of the hand and the wrist, T1 on the medial aspect of the forearm and the lower half of the arm, and T2 in the around the axilla region. Similarly, if we go lower down in the chest, the T4 corresponds to the nipple level, T7 the xiphoid, umbilicus with the T10, and just over the pubic symphysis it's T12. Lower down, if we go, then this is the diagram which one should memorize. L1 is over the area corresponding to the femoral triangle, L2 over the anterior aspect of the thigh, L3 over the specifically over the anterior medial aspect of the knee, L4 over the medial aspect of the leg, and the specific dermatome is over the medial malleolus, L5 over the first interdigital space, and S1 is over the heel or the lateral aspect of the foot. Now these are the sensory dermatome, and coming to the coming to the reflexes. Where is that? Yeah. So cervic, I must have kept it in other slide. Now coming to the bony landmarks. Now the prominent spinous process over the back, the first one that we'll get is the C7 spinous process. The medial scapular spinous process that will correspond to vertebrae spinous process. T7 spinous process will correspond to the inferior angle of the scapula. The L2 spinous process will correspond to the lowest vertebral lowest rib that is being palpated, that is the D12. Though this may vary, because at times somebody has an 11 ribs only, and L4 spinous process corresponds with the iliac crest. Now, why this is important? Because when you're doing the bony palpation, many times just based on the palpatory findings, we should be able to localize where the lesion is, especially if there is a knuckle or a tenderness which is being appreciated. Now, various conditions of spine that we come across, in general, what I have learned during my orthopedics, this is a mnemonic which I used to remember. So, SIN2, like you can have your own mnemonics, but in any pathology, wherever you come across and you have to write a paragraph in an exam, this is what you can follow. This is basic classification that you can have. A congenital, scoliosis, kyphosis, or spina bifida. Infection, it can be either tubercular, pyogenic, or fungal. Neoplasm, primary or metastasis. Trauma, fracture, dislocation, or osteoporotic fracture. And others like degenerative, like myelopathy, cervical or thoracic myelopathy, lumbar canal stenosis, disc disease or listhesis, and inflammatory like ankylosing rheumatoid and ankylosing spondylitis. Now, once we come across the patient, what's most important thing in spine is 90% of diagnosis can be made only based on the history and the clinical findings. So we have to be very particular on this, and we have to spend adequate time to know the history. So in history, you first you check out what's the age and sex of the patient, because there are many conditions which have more propensity to occur in a particular age or in a particular sex. Occupation, why occupation is necessary? Because in some occupation the patient must be straining the particular kind of muscles more, or like a banker, they are more used to sitting, or a laborer who is more potter who lifts heavy weights on his head. So these people, they have more tendency to have cervical pathology. So you need to ask about the occupation as well. The chief complaints, so whatever the chief complaints are, we need to have details of the chief complaints. I will be presenting in next slide. The history of the complaints, what are the aggravating and the relieving factors, what's the treatment history, what's the history of any medical history or surgical history in past, and any associated family history. Now in age, there are like scoliosis or bifida. These we come across more in a child. In adolescent, usually they present with scoliosis or Scheuermann's disease or a mechanical back pain, and at times with infection. Young adults can present with disc fracture, ankylosing spondylitis, or infection, and middle age with listhesis or spondylosis and tumors and disc. And in elderly, one should be always be suspicious about a severe pain occurring because of trivial trauma, might be because of osteoporotic fracture or a metastasis. Similarly, male are more prone to have ankylosing spondylitis and disc osteoarthritis, whereas in a lady, we must be well aware of osteomalacia. The prevalence is higher in ladies, and also there is at times psychogenic back pain or back pain associated with menstrual history. So all these things has to be taken out while you're discussing, you're taking the history. Now, the main complaints with which the patient presents in spine pathology are either pain, weakness, swelling, deformity, and the difficulties the patient has because of any one or more of these. So whenever we come across all these things, we need to have a detail of how is the pain, what is the site of the pain, is it a throbbing kind of pain, sharp shooting, radiating, dull ache, non-radiating, is it aggravating on particular activity or getting relief by particular activity? What is the progress over a period of time? Is it getting better or is it getting worse? Is it associated with rest pain? And what all disabilities it is causing in daily routine activities? If there is a swelling, we need to know what is since when the patient has a swelling and all the details about the swelling, whether it is increasing, decreasing, throbbing kind of pain is associated or not. Deformity, if the patient complains of deformity, we first need to ask the patient, when have they first noticed the deformity? Is it progressing? Is it progressing slowly or rapidly? Is it associated with any other symptoms or any other spots notice, skin lesions? If they complain of weakness, then we need to check out whether the weakness is recent onset, is it a sudden onset weakness or insidious onset weakness, Is it associated with any sensory component or any involvement of bladder and bowel? Is it a unilateral, or is it associated with any symptoms which may point to upper like cranial nerve involvement, like slurring of speech or deviation of the mouth? So all these thing details we have to ask, because at times a human lesion which we think of is of cervical origin might be actually because of something in the brain. So we need to even rule out in that history as well. And always try to ask the patient, after the patient has given you all the detailed history, ask those all direct questions which the patient has missed telling you. Now, once the history is done, we have a fair idea as to what we are dealing with, whether it's a disc. So if it's a sudden onset back pain, which started and is subsiding, but as the pain is subsiding, there is an increase in leg pain. So it points out towards the disc symptoms. Or if there is sudden dull aching pain, which happens more while walking, but gets relieved when the patient takes it. So this is more like a claudication. So if there is a severe pain which is more at night time, which doesn't allow the patient to move, doesn't allow the patient to change posture, get up from the bed, and all those things, that means there is something serious like a tuberculosis or a tumor kind of thing which has disturbed the sleep as well. So based on the history, we know like where we are going, where we are heading towards. And once we know that, then comes the part of examination. Now, as it's true in other symptoms systems, examination is of the same type: inspection, palpation, then the neurological examination, in which we have to check out the motor, sensory, reflexes, and check out some special test. Now, as soon as the patient stands, the stance of the patient, how is the posture of the patient? Now, this is very important. How the patient is standing, whether the patient is standing erect, whether the patient is standing with heel to hand to knee support, or whether the patient is standing with a tilt on one side, which is called as a sciatic scoliosis or a list. So those things has to be noted. Then make the patient walk to check the gait. Once that is done, we have to check out whether the patient is able to walk on the heels, whether the patient is able to walk on the toe. Check out what the normal spinal alignment. This we have to check out from back of the patient, like from the behind side posteriorly, as well as from the side. And if possible, strip the patient to check out if there is any associated muscular wasting or spasm which is causing obliteration of the normal spinal alignment. We all know there is a cervical lordosis with kyphosis in the thoracic and lordosis in the lumbar spine. So if there is a spasm, this deformity, this normal alignment gets deformed. Either there is a hypolordosis or hyperkyphosis at the thoracic level. So those things can be noticed only if we strip the patient. So that's very important. And also that leads us to check out if there is any associated findings, like a previous scar of a surgery or any swelling that the patient has. If there is a flattening of the curve in the lumbar spine, that is reversal or of the lumbar lordosis, it might be because of spasm, which can be present because of the protruded lumbar vertebral disc, or osteoarthritic changes because of the facetal arthropathy, or there is an infection leading to spasm, or in cases of inflammatory condition like a ankylosing spondylitis, in which there is a gradual decrease in the mobility of the joints. Or there can be increase in lordosis. Now this lordosis might be normal in cases if the lady is pregnant, or in cases in which there is a very high pelvic incidence, in which the sacrum is quite horizontal, and to balance the horizontal sacrum, the lordosis is increased to balance it, to have a normal sagittal axis. Similarly, spondylolisthesis, those can present with increased lumbar lordosis, or if there is a associated thoracic hyperkyphosis, which is more than normal, the patient can have increase in lumbar lordosis. In cases of deformity, Again, the basic principle is same. You have an inspection right from the posterior side, from the front and from the sides. In this, we have to notice how is the head position over the pelvis, how is the shoulder, whether it is leveled or not, position of the scapula, is there any chest asymmetry, level of nipple, how many curves do we appreciate, whether there is one which is major, which is the maximum thing, that is called as major, which is milder one is called as a minor. What happens to this curve on bending forward, whether there is associated rib. On bending, does the curve decreases? When you make the patient prone, does the curve decreases? So these are the things which we have to see in a deformity cases. Along with this, try to check out if there is any skin lesions like a capsular spot or any neurofibroma seen. So these are the things which one should see on an inspection in a scoliosis patient. And next comes the further examination when we make the patient walk. So in a gait, one has to ask the patient to walk freely for some distance. Now, this is a typical unsteady gait which is usually seen in a human kind of lesion. Ask the patient to walk, observe from front and back. Now, this lady, she has got a antalgic gait and is crouched forward. We can appreciate hardly there is any range of motion possible because the patient is having pain on extension. Whether the patient has high stepping gait in a case of foot drop, then ask the patient to walk on a heel and walk on a toe, because this gives us a fair idea whether we are dealing with L4 pathology or L5 pathology or S1 pathology. Because if the patient is unable to walk on the toes, that means the S1 is weak. If the patient has heel weakness, dorsiflexor weakness, it is L4-5. Next comes the range of motion. Ask for the front and back movement of the cervical on the sides, cervical spine, then lateral bending and lateral rotation. Same thing true for lumbar spine, thoracolumbar spine. You have to ask the patient to bend forwards and backwards, keeping the knee extended, and at times make the patient sit and then check for rotatory movements. If there is some early lesion, the rotation are actually painful. After we have done with this inspection, inspectory findings, then comes the palpation. In palpation, we have to palpate across the spinous process and along the paraspinal region. So in spinous process, we check out if there is any localized tenderness or any deformity or a knuckle present over there. And paraspinal region, we have to check out if there is associated paraspinal muscle spasm. If there is any swelling, check out the whether there is associated rise in temperature, what is the consistency, and how far the swelling is extending, and its relationship with the bones and the muscles underneath. Next comes the neurological examination. Now, neurological examination we can divide into motor as well as sensory and the reflexes part. First, we have to appreciate what's the tone of the muscles, whether it is a normal tone, hypotonia, or hypertonia. Because in upper motor human kind of lesion, we will come across a hypertonia. We have to test the muscles across all the major joints, and a video I will be showing in later half. Sensation before we do any reflexes kind of thing where we actually hit the patient, you complete the sensory part. Even at times people sit, you do the sensation part before you do the motor examination. Now, sensory part, whenever we are doing, make the patient lie down completely, let the patient close his or her eye, and then compare each sensory dermatome with respect to the forehead sensation that we takes as a normal, and then compare it on both the sides, whether it is the patient has hypo or hyper aesthesia in that particular dermatome, and then check out for the reflexes. Now, reflexes, upper limb, we check for the biceps and brachioradialis, triceps, and a Hoffman sign. And in lower limbs, we check out for the patella and ankle reflexes and the plantar reflexes. The superficial reflexes, which many times one forgets, is the abdominal reflex that you should always see, and always do a anal tone and anal reflex examination. Bulbocavernous one is also important, but at least the anal tone and reflex should be examined in an exam, because your examiner will be very much focused on this. So apart from this all things I will be showing in a video if time permits. Special test, the SLR test. Now remember, there is a nerve which a nerve have got some play. So whenever do we do an SLR in which the patient is lying supine, keeping the leg straight, we do passive flexion at the hip joint. You raise the leg, keeping the knee fully extended. Now if the pain recurs, the same pain which the patient complains, that recurs in the thigh or in the calf or in the buttock region, on raising the leg between 30 to 70 degrees, then the SLR is said to be positive. Below 30 degrees, if it is happening, then it is not because of the spinal pathology, it is because of local pathology, because every nerve have got some play, some length to accommodate, and in first 30 degrees the nerves doesn't get stretched. So that is something that we should remember. Leg raising test, that is the cross SLR, in which if we raise the normal leg, the patient will have pain in the pathological leg. So this is highly specific test, but it's not very sensitive test, and it's usually seen if there is a significant or a severe amount of compression seen in that particular level. Lassague's test. So after you get a positive SLR, you slightly lower the leg, and then you do dorsiflexor. So of the at the ankle joint. So if that is coming out positive, it is highly indicative of a positive SLR, and this is called as a Lassague's test. This also helps us to rule out that the patient is not maligning his pain. Bowstring test, this is another in which after you get a positive SLR test, you just decrease the extension, that is you make the knee flex, and then you do the palpation at the lateral tibial condyle, in which the sensitive nerve will get stretched, and that will cause pain. Femoral nerve stress test. So femoral nerve, it has a done roots supply from L2, 3, and 4. So these supply the anterior part. So to check out the femoral nerve, the stretch test, we have to make the patient prone, keeping the hip extended and knee flex. We have to further extend the hip in the upward direction, and if the patient has replication of the same anterior thigh pain, then the FNST test is said to be positive. Now, similarly, there are special tests for the cervical pathology. So, like if there is a disc lesion and you make the patient sit on a stool and then you further do compression, then the pain will get exaggerated. If we apply a distraction test, then the patient will have some relief in the symptoms. Similarly, if the patient walks into a cabin with the hands over his head, that in that position there is some relief of the compression of the nerve root, and the patient has relief. So just keep in mind, this comes in the history, which I forgot to add, sorry. Another test like Valsalva or Solong, in which in one doing a Valsalva maneuver, the intracranial or intrathecal pressure increases. So if there is a tumor or kind of a disc kind of thing which is present there, then the symptoms will get exaggerated. Similar kind of swallowing test, in which if the patient is allowed to swallow something, then there might be replication of pain. This is usually seen if the patient has got huge amount of osteophytes anteriorly present. Lehermit sign, in which if we do simultaneously flexion at the neck as well as hip joint, the patient gets a shooting pain down the from the cervical down the thoracic level. Schober's test, this is another special test in which we check out the mobility of the spine. So to do this, we first make the patient, we go on the backside of the patient, and then you palpate the two dimples across. You come across this point, draw a horizontal line, draw a vertical line right in the center, 5 centimeters below this horizontal line and 10 centimeters above this. And then you make the patient bend forward. So, and then measure. Once the patient is in a flexed position, you measure the length of that line. So if the line it increases more than 5 centimeters, then it's said to be a normal range of motion at the lumbar spine. If it is decreased, then there is some pathology, and it's significantly decreased in patient with ankylosing spondylitis. Another test, sorry, I missed the Trendelenburg's test. Trendelenburg test is very important, in which we again palpate these two lines, these 2 points on the back side. We stand on the back of the patient. Again, strip the patient till you see both the dimples on the either side. Place your thumb on both the dimples. Ask the patient to stand on one leg and keep the other leg in slightly flexed, 10 to 15 degree, around 15-degree flexion in hip, as well as 15-degree flexion in knee. If the patient is able to stand without tilting of the this sacral point, then it's said to be negative. If the patient is having a weakness in the hip abductors, then the pelvis will try to tilt, and the patient won't be able to hold the leg for a longer time. If it's occurring within 10 seconds, it is said to be positive. If it occurs between up to 30 seconds, after standing for 30 seconds, it is called as a late Trendelenburg's positive. It is usually appreciated in seen in if there is a associated hip abductor weakness. Another special test is Romberg's test. In this Romberg's test, you stand behind the patient, ask the patient to stand straight with both of his with his feet closed together, and then the patient is supposed to look forward and then close his eyes. If the patient closes his eyes and is able to maintain his posture, then it is called as negative. And the moment he sways, that means it's a positive sign. This is mostly indicative of the posterior tract, that is a sensory part involvement, and at times it is more quite early positive in patient with UMN lesion, cervical myelopathy cases, even thoracic myelopathy. Once we have done with all the spinal examination, what we need to rule out is the sacroiliac joint and the hip joint. At times, these are the culprits. These actually fool us, and we have to rule out this with Faber's test and compression distraction test and other test for your hip joints. Peripheral vascularity has to be checked, and because in clinical practice you will come across at times with claudication, which might be because of the vascular thing and not because of neurogenic origin. So just keep that in mind. Let not be fooled by osteoarthritis hip or knee or any hip pathology. Similarly, gait is very important, and also one should examine the cranial nerves so that we don't miss a brain lesion and suspect it to be a cervical pathology. Now, this is a video. It's almost 10 years back I had shot with one of my colleague. Yeah. So you first examine the gait, ask the patient to walk, give adequate time to see, ask him to walk twice or thrice. This is the toe walking to check the S1 root. Then ask the patient to walk on the heels. So if he's able to lift the heel, then that means the S1 is functioning properly. Then walk on your heels. Patient with foot drop or early foot drop or early dorsiflexor weakness won't be able to walk in this fashion. Then keeping the knee straight, hand straight, ask the patient to bend forwards, then backwards. Then on either sides, lateral bending. Ask the patient to sit cross leg. This virtually rules out that there is no problem in the sacroiliac joint. Then neck movements on either side. That is a lateral rotation for C1, C2 pathology. Check out for the upper limb shoulder mobility. At times, the shoulder impingement syndrome that confuses us with the cervical pathology. So do examination of the shoulder as well. Now, this is how the sensation is to be tested, except that the eye should be closed. So the thumb is for C6. Now this is for the C5, middle finger for C7. And check out the hand grip, the C8, pinch, C8 and T1. finger abductors, the intrasha, that is T1. Then ask the patient to flex, let the patient have his hand in flexion, stabilize the joint. This we can do in sitting as well as in lying down position, whichever is preferably in lying down position. This is for the triceps. This is for the hip flexors. Then stabilize the thigh, make the patient extend his knee, and then try to push it against resistance. So that was our quadriceps. This is for the hip abductors. We'll come across other things also. This is checking of the tone. You don't allow the patient to move the legs. You do it yourself. Check out for the pelvic lifting. So if the patient doesn't have any pathological pain in the spine, the pelvis region, that will be possible. This is SLR, keeping the knee straight, passively raise the leg. EHL testing, keep your fingers right at the tip of the extensor hallucis longus. FHL testing, dorsiflexor, and then plantar flexors. Then for the sensory dermatome, L5, S1, specific region for this S1, and then lateral malleus for L4. Medial aspect of the knee, that is L3. This is how the knee reflex is to be seen. I hope you have seen that the knee was in flexion. The knee was in flexion, and even when you're doing the eliciting the ankle reflex, the knee was in flexion, and you hold. I hope, yeah. You hold the foot, and this is how the plant is to be seen. Now again, we'll show you that it's being rubbed on the lateral aspect, go up, and then you turn it medially. In that, if the patient has a positive plantar reflex, then there will dorsiflexors, dorsiflexion of the great toe and fanning of the toes. Along with this, there is contraction of the IT band. So these are the various components of a positive extensor, and which will be seen in a human sign of lesion. At times there is flexion, so that is a normal response. At times there is no response, which is considered as an equivocal. Similarly, for biceps, place your finger and then thumb over it. Triceps triceps and brachioradialis. I think we have missed the Hoffman, showing Hoffman's here. Now this is for the SI joint. Faber's test, stabilize the pelvis, and then do the figure of 4 test. This is the hip abductus being tested. So against gravity, that's possible. Now against resistance, that is possible. Apply the hand at the knee joint and not at the ankle. Okay, this is for the knee flexion. Patient is prone, ask him to flex and then hold it. This is femoral nerve stretch test, FNST. Yeah, so that was it. Sir?
So you've done, Gautam?
Yes, sir. Yes, sir, I've done. So
okay, great.
Yeah.
So we can go on to the questions.
Yeah. The TNBs, please ask.
Hello, sir.
Yeah.
Sir, I have 2-3 questions. First one is, sir, you have Gautam sir says range of motion must be inspected. Matlab, it come in inspection, but in book it's given it comes after palpation in movement part.
Sorry.
Range of motion of the cervical, thoracic, or lumbar joint come in inspection or come after palpation.
Gautam, you want to answer that?
For DNBs,
No,
Yeah, I
sir,
think so.
standard.
Yeah, so when you're doing that for your exams, yes. Okay.
It come
So,
after palpation.
yeah.
Okay, sir. Next question, sir, said that for SLR, significant angle is 30 to 70 degree. Before 30 degree, nerve does not get stretched. That's why it's insignificant. But why it is insignificant after 70 degrees?
yeah. So after 70 degrees, there is a hamstring stretch. So that's why.
Because we have read
Hamstring,
about the hamstring angle also. When you see in CP case, there is one term called hamstring angle.
What is it, sir?
Yeah, I think when you straight your leg to 90 degree, there is slight flexion at the hamstring, about 15 to 20 degree. So you cannot straight your hip joint when your knees is straight to 90 degree. That's
see,
why.
after this 70 degrees, there is hardly any movement at the nerve root. There's okay, and beyond that, if there is anything possible, at times the hamstring gets stretched. So because of these two reasons, there's no point in seeing this beyond 70 degrees.
Yes, sir.
So what it
Because
means
nerve
that,
has got 2 to 4 millimeters this lag
Flexibility.
kind of thing, so where it can move, and this length that increases as we go lower down. So in that slack, the nerve length slack is there. So initial 30 degrees it takes for the slack to reach the point where it can be stretched, it can be tensed. So for first 30 degrees it's of no use, but beyond 70 degrees the root there is no change in the mobility at that particular joint of the lumbar joint. So the root doesn't get further stretched. All the flexion is happening more at the hip joint and not at the lumbar segment. So
no,
beyond 70 degrees, it's not useful.
I think it's more related to that even a normal person beyond 70 may have trouble doing an SLR. Okay, so you, if you are examining a patient and he can get to 70 degrees without a problem, that means it's not a problem related to the disc causing a nerve root irritation. Okay, it could be just problem. I mean, if you examine normal people, some people will have doing an SLR beyond 70 degrees. I
Especially
think,
no patient.
yeah,
Yes.
it's more related to that than anything to do with. You're right about the first 30 degrees because the nerve doesn't start getting stretched till then. But I think above 70, some people would have trouble anyway. So you can't call that as a positive SLR because you cannot clearly differentiate whether it's something different from normal.
Okay, sir. Next query is, sir, in well leg SLR, also there is any defined angle, just like normal SLR angle 30 to 70 degree.
So if it happens in the same range,
Range.
the opposite leg gets painful. The same pain which is being with the patient presenting to us, then it is called as cross SLR or well leg SLR. Same range.
Sir,
Okay, sir.
sir, about crossed SLR, I have one query. Sir, how does it work? Cross SLRs, other side of leg should stress the nerve root of other side. So why it cause pain, sir?
So you know this phenomena kind like SO if there is an axillary disc.
Yes.
Yes.
So if there is an axillary disc, the root gets irritated. So to prevent the further irritation, the body gets tilted on one side, on the same side.
Yes.
If it is a shoulder disc, it will get tilted onto the opposite side. All these things happen. So it is called the main mnemonic to remember in that is SOAS, shoulder opposite, SOAS, axillary same side. So the body gets tilted. The same phenomena applies even for the crosses. So the nerve is getting so much irritated because there is a big fragment that on raising the normal leg, the opposite nerve root gets more irritated. The mobility happens. And that's why it is called as a cross SLR. This is highly specific of being a large herniated disc or a large extruded disc.
Yes.
Yes, sir. Sir, one query about the Tredelyan work test. Why only 10 to 15 degree flexion in opposite limb should be taken?
You tell me. This is related to hip also.
Don't know exactly, sir.
Yeah. So if you further do that, okay, then the psoas muscles comes into the play.
Yeah.
If you flex at the hip more than 15 more than 20 degrees, the psoas gets into the play. So you are the mechanism which is more because of the hip abductors gets slightly camouflage or something cover up, like that kind of thing. So it should not be flexed up to the 90 degrees, just around 20 degrees, something like that, 15 to 20 degrees.
Okay, sir. One last question. What is sacral nutation? Not related to examination part.
Sacral
Nutation.
mutation.
Nutation. And how it is related in low back.
I'm clean gold. Sorry for that.
Okay, sir. Thank you.
Okay, Amit. Amit and Sumit must have some questions.
Yes, sir. Sir, I have three questions. In a patient of skeletal tuberculosis, the dorsolumbar lesion being the most common cause, most common site of spinal tuberculosis, supposedly a patient comes to us, and in the exam we are uh, expected via our clinical examination to localize the lesion. So is it supposedly like it is in the lumbar area? So we have like different type of symptoms or signs to elicit it, like EHL or FHL weakness, the abductors, adductors, and n number of things are there. But how to localize these lesions in the dorsal spine? Is it via only the pain on deep thrust or palpation that we say that the lesion is there also in the dorsal spine, or are there any tests for that?
See, Amit, the deficit in a tuberculosis can be because of the bony destruction. Okay, so
Okay.
that is usually interiorly. So always you won't get a tenderness at the same site. Okay, it can be because of the abscess also. It can be because of tumor syndrome, because of the granulation also. So every time you won't be lucky to have a tender spinous process. Every time there won't be a knuckle or a gibbous. Okay, and even if that is present, then localizing it with the help of scapular at times might the scapular's lower end and all can be difficult. So what's actually important is first you localize the neurological deficit. By
Okay, sir.
neurological deficit, it means the motor deficit, and it also means the sensory part. Now in sensory, it's more important. Always remember where the sensation is. So it's like xiphoid process C7, sorry D7. The umbilicus is D10, and just in the around the symphysis is 12. Between this, you have to divide those parts, two finger plates, and all those things that you have to do. So once you know the sensory, then you check out and you have the corresponding level of the lesion with the nerve roots. Now, as you between T10 and 12, all the conus is present. Okay, so all the roots quadra equina will be given up there. But in higher side, as you come above, like in cervical spine, C5, C6, there will be more affection of the C6 root. Similarly, in the upper thoracic, you have to add one root. In the middle thoracic, you have to add two root. And in lower thoracic, from D9 onwards, you have to add three levels. So if you are getting a sensory level as say D9, then the lesion is probably at D7, D8, because you have to go higher up by two segments. Did you get it?
Right, sir. Sir, my second question is that what I am often confused in examination is the spasticity and the rigidity part. And supposedly, like spasticity, they say that it is velocity dependent increase in tone, and rigidity, it say that from initiation of the movement, the limb will be as if there will be difficulty in movement. And if there is spasticity or if there is rigidity, what do we infer? Like, what is the inference that we get from these two terms?
See, this passes more because of human science. So it can be because of a brain lesion, or it can be because cervical cord level lesion. Okay. Now rigidity, it's usually present in an extrapyramidal syndrome, like a Parkinson's and all those, which I have forgotten. But it's more because of extrapyramidal. So there, the main pathological difference is there. In spasticity, it will be like totally tight, and in rigidity, it might be like a cogwheel kind of rigidity, in which it comes and goes, it just leaves and it again contracts kind of thing, or it can be clasp knife like a rigidity. So it just gives you. So it's very easily appreciable whether it is a rigidity or a spasticity, and the lesion is totally different. The reasons are different, so you need to differentiate it.
Right, sir. Sir, my third question is on these tendon reflexes. Either the tendon reflex is absent or it is exaggerated, but sometimes we get what is known as brisk, or the book writes that the tendon reflex is brisk. So if it is brisk, then what do we infer from that? What is the inference? If the
Exaggerated.
tendon...
Brisk is exaggerated. Now,
Okay, sir.
exaggerated can be because of a pathology, or it can be even because of anxiety. So that usually that we come across is a knee reflex being brisk. At times might be because of anxiety also. Suppose you suddenly jerk the patient is unaware, you don't tell the patient before like what you're going to do, and suddenly hit it. So the sight of hammer is good for you, but for the patient it might be something very painful. So that can lead to some anxiety leading to brisk reflex. So you have to confer at the end, doing the reflexes and then checking out with the plantar. So if the hyperreflexia or the brisk reflexes are present without a plantar being upgoing, then probably it's more because of anxiety.
Anxiety.
Now you tell me when a plantar upgoing is normal.
Sir, phases of deep sleep.
Sir, in the neonate.
Correct. So these two things you just keep in mind. So apart from this, whenever you get a plantar upgoing, it is pathological, highly pathognomic of a human sign. Okay. And then
Sir,
you have to correlate everything.
Sir, one last question, sir. Sir, it is more of a theory question, sir, but it is, I do not understand it. What is the difference between cauda equina and a conus medullaris on presentation? Like clinically, how do we decide?
Clinically, cauda equina is more lower down. Okay, so it may be because of it can start with a single leg, single leg getting affected, and cauda equina usually comes with foot drop of toe weakness with ball bladder involvement. The same thing can be with conus medullaris, but in conus there might be at least at times is sparing of few roots and involvement of other roots. So the pattern might not be symmetrical on both the sides, whereas in cauda equina is usually symmetrical. Though in the definition it might begin with one being more affected than the other, but in conus medullaris it can present with asymmetrical kind of thing, or it's more asymmetric kind of thing, and you have even upgoing plantars at times in conus medullaris.
So I think the basic difference is that in the cauda equina you'll only have lower motor neuron features. Okay, so you will not have any spasticity or increased. While in the conus you may get a mixed picture of upper and motor neuron sort of symptoms. Okay, and similarly spasticity and rigidity, I think it's related to the tightness through a range of motion. Okay, so in rigidity it's almost constant, while in spasticity, if you keep pressing a muscle for some time, you'll find that it relaxes over a period of time because it's related to the muscle being in spasm. So like when in a cerebral palsy child, as you dorsiflex the ankle, over a period of time, you'll find that it gives way. Okay. So while rigidity will be rigid, the same rigidity throughout the course of movement. Okay.
Right, sir.
So, any other question, Amit?
No,
Okay.
sir. Thank you,
sir. How to rule out the malignancy?
Sir,
Yeah,
I have
Avinash.
Sir, how do we do when we say, sir, autonomous bladder and automatic bladder? Sir, how can we differentiate in on the basis of history and examination?
So whenever there is too much of means autonomic is it's not regulated by the usual the pyramidal tracts. So
Yes.
whenever the bladder gets filled, it just empties.
Yes, sir.
So that's more like a reflex bladder that we came across. An autonomous.
Sir, they say autonomous bladder where the sacral cutoff is there. There is no connection with sacrum. So when it get filled, it get so overflow of the urine is there. And automatic bladder due to UMN lesion. So there when it get filled, it has the sensation and get void automatically. So in theory, it is very clear, sir. But I think on the basis of
Practically differentiate it in a patient who comes in clinic, it's very difficult to differentiate this.
oh yes, sir.
Because
If examination, what to say to the examiner?
So
just
you
have to
got
recite.
you know the answer, Avinash. That's what you say. So in
Yeah.
examination, so retention with overflow will be different from an automatic bladder. When you get retention with overflow, you will firstly you'll be able to palpate a bladder. Okay,
Yes, sir.
and the second thing is the urine will kind of dribble out. Okay,
Yes.
not like a clear flow of urine. While in an automatic
I was confused because in both of cases sir, urine the patient will say कि I generally void urine without I knowing. So
yeah, but here you will have a clear stream of urine. There will be like a dribbling with incontinence, yeah?
Yeah.
Overflow incontinence, yeah.
And in overflow, the bladder size is also big.
Yeah, so
And
it's,
in
so it's palpable, yeah.
yeah, in
Automatic,
automatic it is small.
yes.
Okay, sir. Like when we are doing SLRT, how to rule out malingers? That patient is not malingering.
malingerers. Wow.
Yeah.
So for that, you can do that boasting kind of thing. The other is Lassegue test. So you decrease it and then you do dorsiflexors. At times, after doing that, you do plantar flexors. So the patient at times are trained to short out everything. You do plantar flexion the opposite side. So if even the patient shouts on that or screams, then he's maligning.
So the other thing is to make them bend standing, okay? So if they can bend standing and touch their toes, then the SLR can't be positive, yeah.
And what they are not aware of, the SLR can be done in sitting position. So once the patient is sitting on the edge of the bed, you just keeping the your hand over the thigh, extend at the knee. So if the patient has actually got a lesion in disc or something, then suddenly with both the hands, the patient will try to go behind like a jerk kind of thing and take help of both the hands. It's if it's positive. Otherwise, he will. If he's managing you, then this kind of reaction would be seen.
And in bowstring, sir, sometimes there is pain while we are just palpating the hamstring. So that we can say that it is positive, or because you have told that some on the lateral tibial
So you have
plateau.
to, yeah. So the lateral tibial nerve is being palpated in that. So that time you have to place your thumb inside the popliteal fossa, inside. So that time, if you palpate the hamstring, it might be painful because of local thing, or the spasm is actually in the hamstring. So the location varies.
And one term which we used like list, sir, that one slight bending of the spinal cord and scoliosis. That is also sometimes asked in the exam how to differentiate.
So the sciatic scoliosis is this lateral bending without any obvious scoliosis. That is the list. And whenever the list is present because of the, as I told you, psoas, same shoulder opposite. So that kind of disc is present. So the patient is tilted. So once you make the patient bend forward, the list usually disappears.
Okay, sir. And you have mentioned
so the
about
patient tilted like this. Once and one shoulder is higher, the other is lower because of the list. And once you make the patient lie down, the spine straighten out.
okay, sir. So that is also differentiation between postural scoliosis, sir, or compensatory scoliosis. That one.
No.
So
Postural scoliosis is where when the patient bends, the scoliosis corrects itself. Okay.
Okay, sir. Yes, sir. And you have mentioned about finger escape sign, sir. That is for what we can do that test, sir, because usually we are not doing during the spine examination.
This kind of thing?
Yes, sir.
Finger. Okay, so this is for the introsci. The abduction is restricted, na?
Yes.
Abduction, adduction of the fingers.
Abduction, adduction. So for that, this is the introsci function. So T1 you check out.
Okay, sir. So if a case of lumbar spine, if it is given, so we can examine the lower limb as well as upper limb. But these things, finger escape sign, we should look for all the cases or for some specific, like when we are suspecting pathology in cervical or thoracic.
No, for every case you have to do entire examination. Even if it's a lumbar spine, you have to rule out that there's no cervical associated.
Okay, sir.
Whereas the patient is not revealing that, but the patient has got cervical symptoms.
But in a clinical examination, you do it, but for your exam purpose, you will not go into details of the upper limb. Okay, if you've got a low back problem, you need to give the details of your lower limb neurological examination. You can just say upper limbs are normal.
Normal. Yeah.
You need to do the basic tests of the symptoms and signs of any neurological involvement in the upper limb, but you don't need to go to details of all the tests there. Okay.
And just one more question, sir. Like when we are writing prescription, we should write that the extension exercise for spine if there is some disc prolapse. So is any case in which we can write the flexion exercise of a spine also, sir? Because usually we avoid flexion in most of the cases.
No. In fact, you need to build up the abdominal core as well as extensor at the same go. You can't have only extensors, because when you do any movement, it's a synergistic action. So because something is flexing, the other thing is getting extended, stretching out. So you have to build up the entire abdominal core as well as the extensors at the same go.
In fact, in patients with spinal stenosis, it will be extension that's more painful than flexion. Okay, so you need to build up the abdominal muscles as well, the core muscles, core spine muscles. So it's a question of, and also mobilization. So it's the concept of not moving your spine because you've got a disc is only in the stage of spasm. After that, you need to start do mobility. So you need to stretch out, you start doing SLR, you start doing bending, everything. Yeah. If you don't do that, then you'll end up with a more prolonged rehab than otherwise.
And sir, for deciding the surgery, sir, one thing we usually ask that pain is radiating below the knee or above the knee. That is very important question. Why it is so, sir?
So that's for localizing the root level, not for deciding the surgery. Surgery is a different thing. Surgery is based on the disability, how bad the pain is, whether there is any deficit or not, and whether there is a response to conservative management or not.
So I think also if the pain does not radiate below the knee, you cannot call it a root involvement. So there's this differentiation between lumbago and sciatica in general terms in spine. Okay, so back pain can extend to the back of the thigh even without involvement of the roots. Okay, when the root is involved, it will go down the leg beyond the knee. Then I mean, these are not absolute these things, but it's an indication that the root may be involved. Okay. Okay, I think we should call it a day.
Most of the.
Sir, I have one more question, sir. Tension and flexion exercises.
You please repeat, Amit. No, we have not.
So rehab in disc as well as in LCS, whether you mean to say whether it changes.
Yes, sir. Is it the opposite? Because the patient will of a disc will have pain in forward bending. So do we need to strengthen the core abdominal and extensor muscle in both of these conditions, or does the rehab changes as per according to condition?
So more or less it remains the same, because whatever the pathology is, initially when the patient has pain, it's more of a isometric exercises that we stretch upon. And after the painful episode has passed on, we need to build up the entire core muscles so that there is further reduction in the chances of having a recurrence of these symptoms. So for that, all the muscles need to be strong enough.
So the difference is that in the initial period, in spinal stenosis, you don't have a problem of muscle spasm usually, yeah? Okay, which you'll have in an acute disc. So in that acute period, you have to be a bit careful in doing too much of exercise, yeah? So there you would give them muscle relaxants, medication, wait for the sort of spasm to reduce and then start the exercises. While in spinal stenosis, the features are more chronic, related to spinal claudication, or depending if they have instability, it'll be related to sitting and getting up after some time. So you need to do a detailed history to find out what is causing the pain, what exacerbates the pain, and then concentrate your exercises based on that. Okay, so core muscle strengthening, eventually you do in both, but initially in this acute disc situation, you have to be a little reserved with your exercise schedule. Okay, so you might have to wait for the spasm to reduce before you start doing too much of exercise.
So in any painful condition, you should just first concentrate on isometric exercises. Once that is possible, isotonic. And once that is possible, then you go for strengthening exercises. So this is the pattern followed for each and every joint across, not only for spine, everything. Isometric, isotonic, and then strengthening exercises.
So, but it's when you say isometric, they are also strengthening exercises. Yeah? But you do weights and resistance and things like that.
So you just keep it like it's strengthening, but you don't do all those against resistance and all those things. It's like exactly, whatever your body is able to bear with.
Yeah, true. So you do other more. So that's, I think, any other questions from the DNB students? Otherwise, I think we should call it a day.
No, sir.
Okay,
Yes.
great. Thanks, Gautam.
Thank you.
Okay, thank you, Gautam, for a very illustrative talk and exam on the details of examination of the spine. And I think that we'll call it a day. Okay, Janki.
Yeah, thank you, sir.
Sure.
Thank you, sir.
Thank you, Gautam, sir.
Thank you. Thank you, everyone.
Sure.